record avada?
Sir.
Last close cheyaledu. Record ayindi ledha. Adi naaku download chesi ivandi net. Ippudu andaru unna students naaku
8.
8.
Yes, sir.
Start chesistanu nenu 8 anna parvaledu. చేంజ్ చేయడం ఇక్కడ నుంచి కదా మీద అప్ చేయడం ఓకే గుడ్ మార్నింగ్ స్టూడెంట్స్ కెన్ యూ హియర్ మీ నౌ ఆర్ యూ ఏబుల్ టు హియర్ మీ కైండ్లీ రిప్లై
Yes sir, we can hear you sir.
You can hear me, wonderful. So whatever number of students, I'm just repeating few things which we have missed, and I'll try to close down the entire lecture within half an hour. Okay. Now, as I have mentioned, today I'm going to talk about neuromuscular blocking agents. Yesterday, there were some technical issues that's why I couldn't complete. There were miscommunication also. That's why I couldn't complete. So I am sure that today I'll able to complete the whole lecture. I'm very keen that you should understand the basics of neuromuscular junction. Unless that is there, you will not understand the subject of anesthesiology. Right now, I'm recording it also. So in case you have missed some of your students, I'll give you the video. So you should be able to understand every bit of it. So as I mentioned, neuromuscular junction consists of nerve end, synaptic cleft, and muscle end plate. Friends, rather students, acetylcholine is a neurotransmitter at neuromuscular junction. I'm sure you understand that. The whole thing revolves around the acetylcholine and its receptor. And the thing which I'm going to talk about is neuromuscular blocking drugs. They will be acting peripherally at the neuromuscular junction. There are broadly two types. One is depolarizing, other is non-depolarizing. Among the depolarizing muscle relaxant, the only drug which is right now we are using day in and day out is choline, succinylcholine. Succinylcholine or scoline, succinylcholine. 3 names, but the thing is only one depolarized. Among the non-depolarized, there are 2 types. One is steroidal and another is another. I'll tell you about the other things. So now the acetylcholine is synthesized as nerve cytoplasm by the combination of choline and acetyl coenzyme A, which is synthesized by mitochondria. I'm sure you understand where is and what is mitochondria. The reaction is mediated by an enzyme called choline acetylcholinesterase. Acetylcholine is stored in vesicles and later released in synaptic cleft. So far so good. Synaptic cleft size is around 2 nanometer. Acetylcholine binds to the acetylcholine receptor at muscle end plate, and this leads to opening up of ion channel. Okay, so that ions can move across the ion channels and depolarize it, producing end plate action potential and triggering contraction of the muscle fibers. So this is the entire gamut of things which happens at the neuromuscular junction. The acetylcholine is destroyed in less than 1 millisecond by acetylcholinesterase. And in the neuromuscular junction, this is also known as true cholinesterase, which is synthesized by the underlying muscle. Why it is known as true cholinesterase? Because there is one more cholinesterase which is in the plasma that is known as pseudocholinesterase. So we'll come to about that later. Now coming to about acetylcholine receptors, you must know that it is a protein made up of 1000 amino acids. These receptors exist in pairs, always in pairs, these receptors in the neuromuscle. I'm talking about acetylcholine receptor. Each pair has 5 subunits. Now you have to pay attention to only one particular subunit, that is alpha subunit, because this is the receptor with which the acetylcholine really gets attached, and even the succinylcholine gets attached to it. That is, the alpha subunits are important because acetylcholine, succinylcholine, and competitive antagonist non-depolarizing drug get binded to this site at alpha subunit of the acetylcholine receptor. The receptor has 2 gates, which I had already mentioned yesterday. Again, repetition. Upper one is voltage dependent and the lower one is time dependent. For producing muscle and plate action potential, both gates should be open. If any one gate is closed, ions cannot pass. So talking about this is entirely about the neuromuscular junction and the receptor. Now, so far, what I am mentioning about this is nicotinic receptor. Now you would ask me, where are the muscarinic receptors? These are very important again. But now it is not important for this particular class. Muscarinic receptors, many functions of parasympathetic nervous system, they mediate. The muscarinic receptors are found in neuronal, cardiac, musculoskeletal, pulmonary, digestive, and urinary system. One more thing which will come in the class, which is very, very important to understand the entire lecture, is strain of 4. When the topic comes, I'll explain to you in further. Now let's come to the first slide. As I've shown you, way back, so many decades ago, arrow poisons used to be used by the people inhabitants of South America. They used to use arrow poisoning, which they used to use unknowingly or knowingly curare. The same muscle relaxant which we are using after so much of research and so much of advancement even today, the same thing was known to our forefathers in America, South America, and they used to kill animals using arrow poisoning, using curare. So that is it. And curare is incidentally a generic name for arrow poisoning containing cubocurare. It is derived from the bark of Strychnos toxifera. Okay, and let's go to the next slide. So coming to the history, which I already mentioned, I don't mind mentioning a few more lines about it. In 1942, Griffith and Johnson suggested about D-tuberculosis. It's a safe drug to use during surgery. Succinylcholine for the first time introduced by Thesleff and Folds in 1952. In 1962, Bade and Reed first administered pancuronium, that is also known as Pavilon. Okay, now in 1962, Bade first administered pancuronium, that is Pavilon. During when I started giving anesthesia, the only drug which we used to use is Pavilon. Pavilon is available in the market even now. It is the cheapest muscle relaxant available in the market. We don't use it now because we have got better drug, this is Vecuronium. The problem with pancuronium was it is a long acting, but it has got vagolytic effect. So there used to be tachycardia and hypertension because catecholamine release also. So this is a disadvantage to some patients, like if they have cardiac problem, tachycardia is very, very deleterious. They can also die. So now the advancement has come to Vecuronium. It's an amino steroid and atracurium, which I said, the other type of best isoquinolonium thing. Mivacurium also was introduced in 1990. The modern drugs like rocuronium, other thing, and even Vecuronium, they come in the group of steroidal group of non-depolarizing muscle relaxant. Definition of NMDA are the drugs that act peripherally at NM junction. NM means neuromuscular and muscle fiber itself to block neuromuscular transmission. Why do we need them? Now the question is basics. I'm telling you because you are first year students of postgraduate MD anesthesia. You are still not very sure and you're not very clear about what is happening and what is the role of neuromuscular junction drugs. Why do we give muscle relaxant? We give muscle relaxant in order to facilitate muscle relaxation for the surgery. Surgery cannot take place unless the muscles are relaxed. The surgeon cannot put his hand inside the abdomen unless the muscles are relaxed. And he cannot reach the actual place of surgery unless the whole thing, the whole field of surgery is completely relaxed. Also, we use muscle relaxant in ICU and during surgery for mechanical ventilation. So unless mechanical ventilation is taking place, I don't think that if the patient is breathing also in between, then there will be disparity, the fighting against the ventilator. So they won't be able to breathe properly, and we can't ventilate the lungs properly unless it is paralyzed by giving muscle relaxant. Vikas and Ravi Reddy, Ram Reddy, are you able to see my face also?
Yes, sir.
Okay. Next, coming to the next slide. So this was the slide which I showed in the initially. This is nothing but axon. You can see this is the nerve end. I'm trying to show the cursor. This is the nerve end and this is the muscle. These are the acetylcholine receptors, this violet thing, and these are the acetylcholine um, being released at the thing. Okay, I'll come back to the previous slide. So can you see this is the end plate? There's a problem in the cursor here. Cursor is not working. Okay, it's going to the next slide. Let me come back to the previous slide. So anyway, you can see very clearly vesicles in the end of the axons. You can see M is nothing but mitochondria. And acetylcholine releasing side, you can see the acetylcholine receptor at the muscle end plate, and that is it. And it is destroyed by metabolized by acetylcholine esterase. See, this is it, acetylcholine esterase. I showed it with the cursor, acetylcholine esterase. Okay. Now, the next slide. Neuromuscular junction, association between a motor neuron and the muscle cell, synaptic cleft. The cell membrane of the neuron and muscle fibers are separated by a narrow, that is, as I mentioned initially, 20 nanometer gap. That's all. The neurotransmitter responsible for neurotransmission at the neuromuscular junction is acetylcholine. This has to be clear in your mind. It is synthesized in the cytoplasm by the combination of choline and coenzyme A with the help of cholinesteryltransferase. These synthesized acetylcholine stored in the vesicles. A single vesicle contains about a quantum of acetylcholine. Now, coming to the next slide. The nerve's action potential depolarizes its terminal. An influx of calcium ions through the voltage-gated calcium channel into the nerve cytoplasm allows storage vesicle to fuse with the terminal plasma membrane and release their contents. Okay, the acetylcholine molecule diffuse across the synaptic cleft to bind with the nicotinic cholinergic receptors. This is the whatever the receptors are in the neuromuscular end plates are there. They are nicotinic cholinergic receptors. Okay, and they get binded to that cholinergic nicotinic cholinergic receptors on a specialized portion of the muscle membrane at the motor end plate. Each neuromuscular junction contains approximately 5 millions of these receptors. Amazing number. 5 millions of these receptors are there in each neuromuscular junction. Among these, minimum of 5 lakh receptors required to be activated for normal muscle contraction. 5 lakh receptors had to be occupied by acetylcholine for the so-called muscle contraction. Amazing, ain't it? The structure of acetylcholine receptor. Each acetylcholine receptor in the neuromuscular junction normally consists of 5 protein subunits, I have already mentioned. There are 2 alpha subunits and rest all are single, that is beta, delta and epsilon subunits. Only 2 identical alpha subunits are capable of binding acetylcholine molecules. So, if both binding sites are occupied by acetylcholine, a conformational change in the subunit, briefly acetylcholine, of which is duration is around just 1 millisecond, opens up the ion channels in the core of the receptor. This channel will not open if acetylcholine binds on only one side. Okay? I'm going a little fast so that I have to complete all the slides within the so-called allotted half an hour for me. Now, as you see, this is the receptor. You can see clearly 2 alpha subunits are there. Again, the cursor, 2 alpha subunits are there. Rest all are single, beta, epsilon, and delta. You can see the structure of acetylcholine receptor. Note 2 alpha subunits that actually bind to acetylcholine receptor and the center channel, which is very clearly seen. Binding of the acetylcholine to the receptors of the muscle end plate causes channel opening and ion flux. This, as you see clearly, sodium and calcium are going in, and the ion, the cation, the positively charged ion is known as cation. The negatively charged ion, like chloride and bicarbonate, are known as anion. So now you are seeing the cation, sodium and calcium are going inside, and cation, potassium, is going out to the receptor to cause the action potential. So far, so good. Another isoform of acetylcholine contains a gamma subunit. instead of the epsilon semi, known as fetal or immature receptor. These are very important, especially in the fetal muscles. They have significant role. I'll tell you what is that after a few minutes. It is also often referred to as extrajunctional receptors. What is the role of this extrajunctional receptor? I'll tell you, because there is a huge problem with extrajunctional receptors, which are present in the fetus. Okay. Okay, briefly I'll tell. The scoline which we use very often, they act on extrajunctional receptors and release extra amount of potassium, and that causes hyperkalemia. Hyperkalemia per se can cause cardiac arrest. That's why that is the problem. After burns and all, after 2 days, there will be production of lot of extrajunctional receptors, which last for almost months together. So after 2 days of burn injury or severe injury, we should not use anything similar to acetylcholine. Acetylcholine most similar is scoline. Scoline should not be used because again potassium will be released from these extrajunctional receptors which have just been formed. Even in fetus, they are already there. So in a child, very newborn child and all, we don't give scoline because of this problem only. Now, coming to the next point, cations flow through the open acetylcholine receptor channel, sodium and calcium in and potassium out, generating an end plate potential. This you should not forget. Okay, when enough receptors are occupied by acetylcholine, the end plate potential will be sufficiently strong to depolarize the perijunctional membrane. Yesterday when I was talking, the person Rami Reddy and I think Sahiti also was answering very intelligently. I'm really impressed. I must make it in record that yes, we have good students also amongst us. I'm sure I'll come to know about other good students in your batch of 14, and I'm sure I would love to interact with you more often. As of now, there is a constraint of time. Let me go to the next slide. Sodium channels are present in muscle membrane. Perijunctional areas of muscle membrane have a higher density of these sodium channels than other parts of the membrane. These sodium channels have two types of gate. As I've already told, voltage dependent and time dependent. Sodium ions pass only when both gates are open. I have already told enough number of times. This is the picture of the same thing which you have seen and understood. With the opening of sodium channels and entry of sodium, calcium ion release. Calcium are released from where? Sarcoplasmic reticulum. This intracellular calcium allows the intercontractile protein, which are actin and myosin, to interact, bringing about muscle contraction. Okay. Now, these are the major steps which happens in the neuromuscular transmission. If you have not understood even 1% of my lecture so far, with this particular slide, you will come to know what is happening exactly. Nerve action potential is transmitted and the nerve terminal is depolarized. Acetylcholine is released from the storage vesicle. At the nerve terminal, enough acetylcholine is released to bind 5 lakh receptors. Acetylcholine molecules bind to the alpha subunit of the acetylcholine receptor on the post-junctional membrane, generating a conformational chain and opening of receptor channels. Receptor do not open unless both alpha receptors are occupied by acetylcholine. Sodium and calcium flow through the open receptor channel, generating an end plate potential. Next slide. When between 5% and 20% of the receptor channels are open and the threshold potential is reached, voltage gated sodium channels within perijunctional portion of the muscle membrane open. When a threshold voltage is developed across them, a muscle action potential, MAP, is generated. Acetylcholine is rapidly hydrolyzed into acetate and choline by the substrate-specific enzyme that is known as acetylcholinesterase. After unbinding acetylcholine, the receptors ion channels close, permitting the end plate to repolarize. Calcium is resequestered in its sarcoplasmic reticulum and the muscle cell relaxes. I'm sure you have understood. Now the classification mechanism and the duration of action. As I have already mentioned, there are two major parts, depolarizing and non-depolarizing. Among the depolarizing, there is only one drug which we are using these days are succinylcholine. Among the non-depolarizing, we have short-acting, very short-acting, anticurium, mivacurium, intermediate-acting atacurium, cis-atacurium, vecuronium, rocuronium. Rocuronium, don't be confused. Rocuronium is not very intermediate, it's slightly long-acting also. We have lost a patient during my army career, not by me, somebody else, one of my colleagues, thinking that rocuronium is very short acting or intermediate acting. Unfortunately, continued acting even after reversal. It continued acting on the patient, and patient went into respiratory arrest and cardiac arrest. So that, however, he was resuscitated. A lot of other problems had happened in that patient. So why I'm saying you have to be very, very careful about the pharmacology and physiology of the drug, and you have to be very alert and constantly monitoring the patient. Otherwise, you may lose the patient or cripple the patient. Long acting are the pancuronium, which I mentioned, Pavilon, pipacuronium, and doxycuronium. Mechanism of action depolarizing NMBA. NMBA is neuromuscular blocking agents. Depolarizing muscle relaxation closely resemble acetylcholine. I have told you enough number of times acetylcholine, if there are two and they bind together back to back, it becomes scoline. So it readily bind to acetylcholine receptor, generating muscle action potential. These are about the talking about the scoline. That's why the fasciculation takes place, because of so-called muscle action potential. Unlike acetylcholine, however, these drugs are not metabolized by the acetylcholinesterase and their concentration. See, I told you acetylcholine is metabolized by acetylcholinesterase available in the neuromuscular within few milliseconds. Whereas similar acetylcholine resembling scoline, they are not destroyed by this acetylcholinesterase immediately. That's why their effect lasts for around 5 to 10 minutes in the synaptic cleft, does not fall as rapidly, resulting in a prolonged depolarization of the muscle end plate. That is the secret of the whole thing. Continuous end plate depolarization causes muscle relaxation. However, if we keep on giving repeated dose of scoline, it causes phase 2 block. That causes total muscle relaxation for a very long period. That is called phase 2 block. I'll tell you more about it in a few seconds. Because opening of perijunctional sodium channel is time limited, sodium channel will rapidly inactivate with the continuing depolarization. Now, coming to the next phases of block depolarizing NMBA. Phase 1 block, I just now mentioned, perijunctional sodium channel cannot reopen until the end plate repolarizes. That's it. The end plate cannot repolarize as long as the depolarizing muscle relaxation continues to bind in acetylcholine receptors. This is called phase 1 block. So far, so good. Phase 2 block, after a period of time, prolonged plate depolarization can cause, poorly understood. This is not very well understood. How this phase 2 block occurs. Only thing you have to know is if you do constantly too much of dose of scoline, it produces phase 2 block. Fully understood changes in the acetylcholine receptor that result in phase 2 block also. Phase 2 block can occur in other situations also. I'll let you know very soon. Mechanism of action of non-depolarizing NMBA. As you are aware, depolarizing muscle relaxant act as acetylcholine receptor agonist, whereas non-depolarizing muscle relaxant function as competitive antagonist. Non-depolarizing relaxant bind to acetylcholine receptor but are incapable of inducing a conformational change necessary for ion channel opening. Neuromuscular blockade. If you have any interruption of your class or anything, as I mentioned, please make me a call. Give me a call immediately. That class is interrupted or disrupted so that I can restart it. Because acetylcholine is prevented from binding to its receptor, no end plate potential develops. Neuromuscular blockade occurs even if only one alpha subunit is blocked. Whereas I am talking about non-depolarizing muscle relaxation. Even if one alpha subunit is blocked, non-depolarizing muscle relaxation still works, but not in a depolarization. It has to have two. Other mechanism of neuromuscular blockade, interference with the function of acetylcholine receptor without acting as an agonist. How it happened? By the addition of inhaled anesthetic agent, local anesthetic, ketamine. If you are giving volatile anesthetics like halothane, isoflurane, sevoflurane, they help in augmenting the effects of non-depolarizing muscle relaxant. Ketamine also does the same, local anesthetic also does the same. Coming to next, during closed channel blockade, the drug physically blocks up the channel, preventing passage of cations, whether or not acetylcholine has activated the receptor. Open channel blockade, use dependent, because the drug enters and obstructs the acetylcholine receptor channel only after it is opened by acetylcholine binding. Example, Channel block in the laboratory include neostigmine, some antibiotic, cocaine, and quinidine. You have not understood? I'll tell you again. If you have given certain type of, only 10 minutes are left for the class. I don't know. Okay, within 10 minutes, I have to finish off as early as possible. Okay. If you're given a monoglycoside type of antibiotic like anamycin, aminoglycoside, this thing, augments the effects of non-depolarizing muscle relaxant. So within 10 minutes, I'll be completing the class quick. Now, characteristic of the phase 1 block. Now, phase 1 block resembles twitch amplitude. When you see the twitch amplitude and absence of fade with the continuous tetanic stimulation. Now, you must know what a few lines about train of 4 to understand this particular slide. Train of 4 is the most commonly used modality for neuromuscular monitoring in clinical practice. The monitor delivers 4 stimuli, each of 2 hertz for 2 seconds, and recordings are taken. Absence of T4 response means 75% blockade of the receptor, which is sufficient for most surgeries. Absence of third stimuli, T3 means 80% blockade, and absence of T2 in second response is also not there after train of 4 stimulation. 90% blockade has taken place. Diaphragm is blocked at this level. Intubation requires absence of all the 4 responses. The only fully relaxation takes place, and you'll be able to intubate with the endotracheal tube into the trachea and give anesthesia. Train of 4 ratio is best utilized to assess the reversal also. First, to see how much of relaxation has taken place after giving neuromuscular blocks, train of 4 essential, and to see reversal after the surgery is over, we give neostigmine to remove the effects of, bear off the effects of non-depolarizing muscle relaxant, long-acting muscle relaxant. Then we have to see whether the muscles are capable enough to breathe enough. The intercostal muscles and diaphragm is able to sustain that enough tidal volume to survive of their own. That is reversal. That is done by the giving anticholinesterase drug. That is, we give neostigmine to reverse the thing. If adequate reversal has been done or not, we have to assess it by using train of 4. Most commonly used muscle for the neuromuscular monitoring is adductor pollicis, and obviously that is supplied by ulnar nerve. The ratio of 0.7, that is 4th response has 70% height of the first response, indicates adequate recovery. But recovery is guaranteed only if the ratio is more than 0.9. Okay? Train of 4 is also useful in diagnosing phase 2 block, which is seen in overdoses of succinylcholine or abnormal plasma cholinesterase activity. So this is it. So if you see this slide, if you what is written, decreased twitch amplitude, depolarizing blockade. When you see the twitch high, it will be stunted, but not after 1 second, third, will not go on decreasing. All of them are stunted, smaller height. That is the difference between this and non-depolarizing muscle relaxant blockade twitches. The absence of fade will be there. Similar decrease in the amplitude of fall of twitches and train of 4 will be more than 0.7. Absence of post-tetanic potentiation, antagonism by the non-depolarizing muscle relaxant, augmentation by the anticholinesterase drugs. What are anticholinesterase drugs? Neostigmine, one example. Pyridostigmine, other example. Now, what are the characteristics of non-depolarizing neuromuscular blockade? Decreased twitch amplitude, fade with continuous tetanic stimulation, train of 4 ratio of less than 0.7, post-tetanic potentiation, absence of fasciculation, antagonism by anticholinesterase drug, augmentation by other non-depolarizing muscle relaxant. Okay. Now, sequence of muscle blockade. First muscle to be blocked by both depolarizing and non-depolarizing muscle relaxant are the central muscle, then the peripheral muscle. So what will be the sequence? First, the muscle which will be relaxed is face, then the jaw, then the pharynx, then the larynx, then the respiratory. After giving scoline, if you see what is happening, first thing reaction you'll see it's in the face, then the jaw, then the pharynx, then the larynx, then the respiratory and trunk muscles, and then the limb muscle. These recovery in the same order. Okay? Depolarizing NMDA. I told you the only drug which is succinylcholine. Let's know more about succinylcholine. Succinylcholine is a quaternary ammonium compound, also called diacetylcholine or succinylcholine. Only quaternary means fourth place, fourth, where the alkyl radical or aryl radical is attached. Or the whole thing is, I'm sure ammonium is NH3 or NH4, you know about it. Only depolarizing relaxant now available in the clinical practice is succinylcholine. Now, this is the structure of acetylcholine. You can see the upper chemical formula, which is serine, and the lower one. Lower one is exactly the same. Two acetylcholine molecules stuck together back to back. Only difference is CH3 has become CH2. That's all. Mechanism of action. Depolarizing muscle relaxant very closely resembles acetylcholine and readily bind to acetylcholine receptor, generating muscle action. Phase 1 block. Now coming to phase 2 block. Metabolism excretion, rapid onset of action. After giving scoline, within the 30 to 60 seconds starts acting. Small volume of distribution due to its very low lipid solubility. Relative overdose, that is usually administered. Short duration of action, usually, as I've said, 5 to 10 minutes is the usual duration of action of scoline. In circulation, rapidly metabolized by pseudocholinesterase into succinyl monocholine. It is metabolized in the plasma by the pseudocholinesterase. It is not metabolized by the cholinesterase available in the neuromuscular junction. That is, as the drug level falls in the blood, succinylcholine molecule diffuse away from the neuromuscular junction, limiting the duration of its action. That is the secret. However, duration of action can be prolonged, or prolonged apnea after succinylcholine can occur due to following condition: low pseudocholinesterase, atypical pseudocholinesterase. As I told you, in the PA checkup, you have to always ask the patient whether they are from Vaishya or Comatlu. They have atypical pseudocholinesterase in their plasma. So they don't metabolize choline. The choline is contraindicated in such people. If you give choline instead of acting 5 to 10 minutes, it lasts for 4 to 6 hours. So you have to be doubly sure whether your patient is susceptible to sensitivity of scoline or not. So you have to ask without fail whether the person is a Vaishya or not. If the Vaishya is there, don't give scoline. There are other methods of giving muscle relaxant. You have to give non-depolarizing muscle relaxant. But don't touch scoline. Okay. High dose of phase 2 block can occur. Hypothermia also causes phase 2 block. And prolonged action of scoline. Decreased level of pseudocholinesterase can occur in pregnancy, liver disease, renal failure. Certain drugs also increases this effect, like icothyroid, neostigmine, phenelzine, and esmolol, pinocorone, oral contraceptives. Atypical abnormal pseudocholinesterase structure of the plasma crystal determined genetically by autosomal gene. Now, few are heterozygotes, so that is okay because 1 in 25 to 30 patients in urinary extraction is with one normal and one abnormal atypical pseudocholinesterase, resulting in a slightly prolonged block. So what I said, scoline affects for 5 to 10 minutes, but in such people who are heterozygote for atypical gene of pseudocholinesterase, the effect lasts for 20 to 30 minutes. But the problem happens in homozygous atypical pseudocholinesterase gene, which are available in Vaishya tribe or Comatlu. 1 in 3,000 patients have 2 copies of abnormal gene, homozygous atypical, that produce an enzyme with little or no affinity for succinylcholine. Now, measurement of atypical pseudocholinesterase can be quantitative and qualitative. Qualitative, most important, is known as Debouquin number. What is this Debouquin number? It's the percentage of inhibition of pseudocholinesterase activity by Debouquin is termed the Debouquin number. Debouquin is actually a local anesthetic. It inhibits normal pseudocholinesterase up to 80%. So, if 80% of the Debouquin number is blocked, so that is the strength of the atypical pseudocholinesterase. If, as I said, heterozygous also can have atypical enzyme, but they have 40 to 60% block of Debouquin activity, Debouquin number. So it lasts for 20 to 30 minutes. But whereas in 80% of Debouquin number, which occurs in atypical this Comatlu tribe, so they have lasting for 4 to 6 hours after giving scoline. Management of succinyl choline apnea. This condition, if it occurs, God forbid, without knowledge, patient has never bothered to tell you that he is from Vaishya, and or an accident, you have forgotten to ask him and you have given choline. Now this apnea has occurred. There is a risk of awareness.